north of the United States, and some people in the United States don't know this. So we are considered north of the United States, and we are the capital city here in the middle of the country, basically. It's one of the biggest province as far as number of population that we are concerned. And I'm currently been involved with them for quite many years. I've been a pharmacist for 35 years in Canada. And I've practiced in both Quebec and Ontario. Just to give you a picture of Ottawa, of Canada, so we get about 2 meters of snow during the winter. Last winter, we have minus 36 degrees Celsius with the wind chill factor of minus 40. Pretty cool. And during the summer, we have a plus 40 with the humidex. So we go from one extreme to another. We have a tulip festival. It's the capital city. We have the longest ice ring in the winter, which is basically the canal that goes turns into an ice ring. Pretty easy at minus 36 degrees. The water really freezes at that point. Pretty easy. I am from a pediatric hospital, and we have a therapeutic hospital. And this is my student. I take foreign student all the times, and he gets to spend 1 day of clowning only. And they keep telling me that's the best day of the rotation. They come to me, so I told them to stop saying that altogether. And this is Peter, when he came to my hospital, but apparently he was disguised as a clown. But he seems to like this, the student and Molly the clown very much. This is my affiliation. This is the logo, but I have another slide to help you. So I want to know where I come from and what I've done to understand what I'm going to be talking about. So I'm the past president of Pharmacists Without Borders, Pharmacists Sans Frontières Canada. My deployment was in Uganda, in a small hospital in Uganda. I'm still on the board of directors of Pharmacists Without Borders. I'm the past president from the Canadian Society of Hospital Pharmacists, which is the Association of Hospital Pharmacists in Canada. So I'm the past president of that group. I'm currently the president of the Ontario College of Pharmacists for another week, which I think is the equivalent of the chamber in many ways. Like, we create the standard of practice, and we also have a group that does a discipline and punish pharmacists. So I'm currently the president, just for one more week, and then get past this one. At the International Pharmaceutical Federation, the FIP, I am past vice president. But I'm currently responsible for the health literacy program and also the pictogram program with the FIP. So all the website, if you go to the FIP website, the FIP Foundation, you will see all the work I have done on pictograms in different countries. I'm also in the buying group, and of course, we have Accreditation Canada. It's a group of people that go and visit hospitals and accredit them, allow them to work. So I've been a surveyor for 16 years. And I've done some international survey. I've been to Qatar, and I just got the news I'm going to go to Belgium in December, so I'm really excited about Belgium. So the presentation divided into about 3 sections. The first section is basically my hospital, what type of services we provide in Canada, and I use my hospital as an example. Then I will talk about scope of practice. Then I'll talk about how can you become a pharmacist in Canada, if any of you are interested. So that usually a type of question that we get. This is my hospital, children's hospital. Only children in our hospital, no adults. We don't do deliveries. This is the statistics. It's important to see this: 167 inpatient beds, but the occupancy is about 87%. Yesterday, we only had 80 patients in the hospital. Okay? But we have a lot of outpatient programs. Our mission is we help kids be their healthier. So that's the concept, and we have a lot of outpatient program, as I said. And I put this organigram there to explain my responsibility in the hospital. So I'm the director. I have a project coordinator, I have students, someone has to do the work. This is I have a drug distribution system. I have an oncology programs, I have clinical pharmacists, and I also have a retail pharmacist I'm responsible for. So in Ontario, the province where I work, a non-for-profit organization can own a pharmacy. So I have a retail pharmacy, and we provide care to patients. And actually, I have a couple of slides to show you how it looks like. We are associated with the chain of drugstore. IDA stands Independent Druggist Association. So even this is a kind of a buying group to buy the drugs, but we're not a chain, so we don't have to do what the chain wants to do. So I'm very independent, but I use the buying power get better pricing on medicine. You can see that this is the drop-off point where patients will drop their prescriptions. Pharmacy technician will process them, put in the patient profile, prepare the drugs, check it, mix it the right drug, give it to the pharmacist for patient counseling. This is where the pharmacist at the other end. And I think I have a better picture in the corner here. You will see this is the semi-private patient counseling area. You see the better picture here. We also do a compounding. In Canada, when we dispense drug, we don't have these boxes. There are very few drugs that dispense in boxes. So if it's 21 tablets that you get prescribed, you get 21 tablets. And we package everything. In pediatrics, we also crush tablets to make suspension all the time as well, because there's not enough pediatrics formulation on the market. So the service we provide, so we opened a retail pharmacy to start make money, let's be clear. It's to make money for the hospital. It's also to provide a service to our patients. We also do flavoring of suspension. So sometimes kids don't like the taste of a suspension, so we have a system to do the flavoring, which is a kind of a service that we do. And we also have a program in Ontario where you can do a medication check. If you take 5 drugs, usually, you can sit down with a pharmacist for 20 minutes and we get paid about $75 for do this checking. And we can provide advice at that situation. We also do vaccination, but everybody does vaccinations in our province, so that's not innovative at all. This is the kit. I want to show you the kit. I heard that you don't do flavoring much here for children. This is a kit, and you have different flavor, and you have a book, and it tells you if you take the amoxicillin suspension from Apotex or from Novofarm, whatever generic company, it tells you if you want that flavor, how many drops of this other agent you need to add to change the flavor. Kids love it. We charge about $4 to change the flavor of a suspension. Few elements from discussion that I've been having with some of you in the last few days. Patient profile is mandatory. We need to record every prescriptions that we dispense to a patient, and we must check for drug interaction every time we dispense a new drug. We also require to document if the drug is working for the patient or not. So if they have significant side effects, if they have any allergies, and our computer system will detect if there is an allergy with the drug the patient already took in the past with the drug that are prescribed. So this is like the basic for us. It's also mandatory by law that we have to document patient counseling on first prescriptions. Patient comes in, the pharmacist is ready to get the drug. It's been checked by a technician. And you need to talk are you talking to the patient or an agent of the patient? And you need to describe what you told the patient as well. And it gets documented and kept on file forever, actually, for 18 years. So this is a structure that allows us to do the care we provide. And it's important to mention because it doesn't seem to be the same thing in Poland. Semi-private patient counseling area is also mandated. So if I do renovation of my pharmacy, which I've done, it's a very small community pharmacy, you have to submit the plan to the College of Pharmacists for them to approve the plan. We also have practice advisor comes every 2 years. Practice advisor, we call them also the inspector. They don't like it when we call it inspector. The practice advisor is responsible to make sure that we have made all the rules, but also that we maintain the patient profile, that we provide patient counseling, and then we identify drug-related problems. And we also have to document the medication errors that we make and have an action plan to prevent them. So that's what moved the practice forward. This is the hospital practice. Okay, remember, we had 80 patients yesterday in the pharmacy, in the hospital, sorry. And my budget for human resources, hiring the staff, is basically $4 million. I have 45 full-time equivalents, so the equivalent of 45 employees working within 1 week, if you want. That's what it looks like, or actually per month. So 45 people. Out of this, I have 19 pharmacists. So yesterday, 80 patients have 19 pharmacists. We are open 24 hours a day, 7 days a week. That's 4 FTE for a pharmacist. And we have pharmacists on different programs. We, just to give there's some data here, but we dispense all our drugs at unit dose. So either in a small package, where we do the barcoding. So the doctor prescribes electronically. The pharmacy gets the electronic version of the prescription. We validate the prescription, get prepared by technicians. We send it to the floor, and the nurse does the barcoding of the drugs to make sure that she has the barcode, and she barcodes herself, the patient, and the drug to make sure the right drug going to the right patients. They still make mistakes, but much less since we implemented that program. Just want to give you a flavor of what we do as pharmacists and which area we are involved with. And this is the FD's number of, any given day, number of pharmacists working. So oncology, have one pharmacist on the ward, 5 days a week. Actually, no, well, 5 days a week. Have a pharmacist checking the chemotherapy. Have another pharmacist preparing the orders for the physician. The way it works in my hospital, the pharmacists write the order based on the treatment protocol decided, so adjust the dose based with discussion with the patient. They want to take a liquid or a tablet, whatever type of formulation they want. He writes a prescription, give it to the doctor to sign it. This is all done electronically. And then the pharmacist checks it to make sure there's no mistakes. So that requires 4 pharmacists all the time. In the intensive care unit, the pharmacists have a pharmacist 6 days a week, and have the neonatal unit 6 days a week as well. So during the day, the weekdays, 2 pharmacists, one pharmacist on each side. During the weekend, 1 pharmacist cover both. They go to rounds every day, and they will ask any or identify any drug-related problems with the physician. They are physically at rounds, and that's their job. They are not in the pharmacy. These pharmacists, you don't see them in the pharmacy. General pediatrics, about 1 pharmacist, sometimes 2, that deal in general wards. So basically, it's the urinary tract infection, pneumonia, meningitis, like the common type of condition in pediatrics. And when the pharmacists know they don't like it, we skip medication reconciliation. But we also have outpatient clinics. So the cystic fibrosis clinic, 1 day a week, when they do a clinic, every time there's a clinic, the pharmacist goes to the clinic. The HIV clinic's the same thing, 1 day a week we have this clinic. The one I like the most, because I'm the one who set it up, is the chronic pain clinic, 2 days a week. Chronic pain clinics, on every Friday, this is the uptake of new patients. And the way it works, you have the physician, the nurse, the pharmacist, the physiotherapist, the social worker, the psychologist around the table. And the patient comes in, it's usually the mother. Who's responsible for healthcare? It's always the mother. Actually, it's always an overprotective mother with a young girl that comes in. That's the typical chronic pain patient. The process is that the patient comes in, a bit scared with all these people, tell their story. There's a physical exam on one end. Pharmacists don't touch patients. See, nice hand, nice clean. Want to keep them clean. Then the psychologist talks to the mother, because the mother is part of the problem most of the time. And I'm not making jokes, this is real. And then we come back together. They go in the waiting room. We come back together as a team, and we come up with a treatment plan. So pharmacist talks about drug. The nurse talks about whatever nurse talks about. But the social worker, usually the social worker, the psychologist, and the physiotherapist give them exercise. And we come up with a treatment plan together. 1 day a week we do this. The pharmacist goes on the follow-up on the Monday and sees the patient have a problem with their drug therapy. They have side effects or anything like that, and they consult with the team. So I really like this program because I set it up. So this is interesting. We have 1 pharmacist working in the emergency department as well. What she does there is very unique, because I thought she'd be taking care of patients individually. The clinical team decides she will work on treatment protocol. So she's the one responsible for treatment protocol in the emergency department. So she will talk to the group of physicians and nurses, can we do it? And then she will come up with an order set, and that's what they will follow afterward. And they have about, I would say, probably 100 order set for different diseases, maybe less, maybe 60 that they have. So it's very standardizing the care. So everybody works at the same level, the same way. It's all evidence-based. Nephrology pharmacists, that's easy, they adjust the dose of everything, so that's pretty standard for us in Canada. I have a new program called pharmacogenomics. Are you familiar with the term pharmacogenomics? Yes. So basically, I'm implementing a new program where the the doctor or the patient will request to be tested for pharmacogenomics to look what type of metabolic pathway he has, what gene that he has. So he will go to the pharmacist. The pharmacist will do a consultation, a medication release review if you want it. Then from this, do a swab of the mouth, send it for testing. The result comes back to the pharmacist, and the pharmacist will write the letter to the physician, and also the patient as well, to the physician, to try to adjust the therapy. That's a brand new program that we're doing. This is done for all patients. This is in the community pharmacy that will be happening. We have a similar program in oncology. So before they start therapy, we will do the testing and see if they are more at risk of side effects with some drugs. So this is for us, this is a new thing. We're all excited about this. We estimate that the cost for the pharmacogenomic testing and the consultation for outpatient would be about $250 Canadian, which would be probably 300 euro. I don't know, it's so expensive. I don't know, but it would be much less actually. It would be something maybe 150 euros. So this is our new program, which we're happy. I can answer any question about this if you want afterwards. I just have this slide to show that my hospital also takes foreign students if they're affiliated with the university, and we get them to work with them research project. I'll show you another slide with the type of research project we're doing. I do a lot of patient counseling using illustrations. Some of them refer to them as spectrogram, but it's really patient counseling tool. I've done one for anaphylaxis action plan, which we have tested. I've done one for eczema, because eczema is very common in our populations. I don't know if it is in yours, so how the patient can better manage their eczema. But I've done other stuff, like we have handling of drugs by healthcare providers. We have one that's very interesting. I'm the pharmacist that supports a palliative care team. So it's Roger Neeson House is a palliative care house where the children are dying, they do end of life. And I'm the one responsible to support them as a pharmacist. I don't dispense any drug, and make it clear. I have pharmacists to do that. But we're working on a decision tool for the management of single end of life. One of them is the dyspnea, so it's probably reading. We call it in French, in English, dead rattles, which is terminal respiration, when the patient have a lot of secretion coming in and out when they die, and there was confusion. So we're developing illustrated decision tool, which will be used by nursing, could also be used by the parents at home. It will also help them to understand what the next step happening with their kids when they're dying. We only have, which is a good thing, maybe 2 or 3 deaths per month in the palliative care house. We also do respite, and we also do symptom management as well. These are some picture of some of the pictogram project we have done that we have used. We adapt them to the environment. Again, very childish type of picture because it's for children. When it's more serious, we make it more. I'll show you the pictogram for the FIP. This is one of our projects. This is 3 projects: the anaphylaxis, the asthma, and the helping to mask the case of medicine. Any tricks? Because if you have any children, giving them medicines are not obvious. So there's very basic trick like peanut butter on their tongue coats the tongue completely, and they don't taste as much. Then you give the medicine more peanut butter, and they will take it. Or ice cream, chocolate ice cream masks the taste very well as well. This is the FIP pictogram that we have implemented, and I think the next picture. This is the FIP, the international level pictogram that we have done for labeling medications, and this is the different country that we have collaboration. Poland is of course with Pure, that we've done the work with Pure, but we have different projects. Right now, the big one that we are working on is validation of the pictogram in the elderly in Singapore, but we have many different ongoing as well. Let's go back and talk about Canada for a second. In Canada, we have 42,000 licensed pharmacists, about 10,000 pharmacies, and about 70% of the people work in the community. And the other is community, or hospital, and industry. It's a very big country. Ontario, where in province I am in, is about 14 persons per square kilometer, sorry. And Yukon, which is the northern side, is 0.1 person per square kilometers. So quite variations. We have the most concentrated province, and most of these people are in Toronto, by the way, because we are at 13 million, and I think 2.6 million are in Toronto, and I think Ottawa, which is my city, is about 1 million. So very a lot of space in between everybody. I like this slide because it describes well how pharmacists think in Canada. We all think that every health substance could be a poison. You can kill yourself by drinking too much water. We also have a professor that defined his profession using one word. Doctors take charge. They are trained at the university to take charge of a code. They need to be responsible and take charge. The nurse have been defined as caring. They need to care for patients. They're the passionate people. The pharmacist is complies with the rule. We like rules and we create our own rules sometimes. Comply with dosing guidelines, comply with reimbursement guidelines and all these things. So I was talking to Damien and talking about all these different rules to get drug reimbursed. This is typical of pharmacists. In my hospital, I tell them it's all about the drugs. If you don't have the drugs, you will not be able to treat your patients. So listen to us, pharmacists. We know what we're talking about. We're the most educated person. And also tell them medicine is an art, and they keep telling this, but pharmacy is a science. So it's important you remember that. And we also the corner store scientists. So basically we take the medical science that's out there, synthesize it to be able to help our patients. So really we are the bookworm of healthcare. So we work very in collaboration. We don't work alone. And it's a very good illustration of how we work. So we have the doctor, the nurse, and the pharmacist that creates this network to be able to provide the optimal patient care, making it as safe as possible for patient care. So to me that describes well how we work together. Then I have a small video to show you that comes from the Canadian Pharmacists Association. It's this internet's a bit slow. Oh, it's fast. There's another one.
In Canada, pharmacists play a pivotal role in the healthcare system by providing convenient, accessible, and high-quality care to Canadians. Pharmacists are an integral part of the healthcare team, working in both your local hospitals and community pharmacies. They work closely with patients, physicians, nurses, and other healthcare professionals to ensure your medications are safe and beneficial. Pharmacists are medication experts. They are trained and knowledgeable in medication-related issues. They help manage a wide range of medical conditions from asthma and diabetes to high blood pressure. In many provinces, you can receive your annual flu shot at your local pharmacy, and in some, other immunizations as well. Pharmacists conduct medication reviews, ensuring your medications are appropriate and effective. They can assess minor ailments like cold sores and rashes, and in some provinces, write prescriptions when needed. Some pharmacists now provide smoking cessation programs, helping Canadians to stop smoking for good. Pharmacists are the most accessible healthcare providers in the country, and continually rank as one of the most trusted and valued professionals in Canada. Their convenient locations make it easy for you to get the help you need, when you need it. Canadian pharmacists help to create a more sustainable healthcare system. Through knowledge and accessibility, they can address health-related issues quickly, avoid drug therapy problems, and reduce emergency room visits and hospital stays, helping to make the Canadian healthcare system more efficient. Talk to your pharmacist. They can help. Canadian pharmacists, providing trusted and accessible healthcare for you. A message from the Canadian Pharmacists Association.
That this is cute. I lost everything.
Low battery, I guess.
It was plugged in. Technical help.
That's hopefully we can manage. It's just that.
I can continue talking because I know what we're going to talk about, and I have another exciting video to show you as well. So we have different scope of practice. Every province, we have 10 provinces and 3 territories, and healthcare is distributed by the province. So what we do as healthcare provider, the province decides. So it really has a different scope of practice, and it can be broken in different categories, the scope of practice. The first one is prescribing drugs. So if you go to Alberta, you can prescribe any drug except controlled substance. So the pharmacists with special qualifications, when they need to certify with their college that they can prescribe any drugs, and it's open book, and they have to document what they're doing. That's no problem. In And that most province will have minor or common ailment, and I do have a list in the PowerPoint presentation of common ailment, but it would be like cold sore, in Quebec, urinary tract infection. So if you have had, as a woman, if you were in the group, if you have a UTI in the past, urinary tract infection, if you have another one within 6 months, so within a year, you know what you have. You don't need to go and see a doctor to get diagnosed, you knew what you have. So the pharmacists are allowed to prescribe the antibiotics for that situation. The situation, if you have had one, I think it's within 1 year, you have another one, the pharmacist can treat you. And after a second treatment, he needs to refer you because you might need more therapy. Yeast infection in women, you can treat. Cold sore, you can treat. You can prescribe the drug in most provinces for tribal medicine, like mefloquine, chloroquine, because you don't need a diagnosis for this. So that's very common. Oh, it's back. Yeah, you're there. So what happened? We don't know?
We don't know.
That's fine. This is the slide I was talking about. This is different scope of practice. I will go in details with pharmacy, because if you look at this, like there's something that's very common to everybody. These are the northern territories, Northwest, Yukon, and Nunavut. They only have very few people, like 70,000 people in some of this territory, and very few pharmacists, and we cannot do much. Ontario is this one, and we have a lot of problem with our medical association who blocks our way of prescribing. So if you look at it, there's always politics. This is the one I was telling you, so depending by province. Smoking cessation in Ontario, I can prescribe all the drug. I can prescribe clonidine, whatever drug we use for like Zyban or what's the name? Like bupropion. If a smoking cessation pharmacist, a lot of pharmacists can prescribe this, like nicotine, whatever, for smoking cessation. This is kind of a quick list of common illness based on the province you're allowed to prescribe, as I mentioned about, like reflux disease, headache, hemorrhoids. Depending on the province, you're allowed to prescribe prescription drugs for this, and they get reimbursed by the drug plan as well. They get considered as a provider for these. The other scope of practice is adapting a prescription, and I have a very nice video that explains it. No, sorry for this.
In Ontario, pharmacists can adapt prescriptions in 4 ways. The first is by adapting the route of administration. For example, adapting an oral tablet.
Okay, so well, I'm almost done here. I should not be touching the computer, that's what I'm learning. So adaptation means that you will change the dose. Sorry, you can change the formulation. So it could be from a tablet to a suppository. So it could be acetaminophen tablet to a suppository. It could be any formulation. Or switching from a tablet to a suspension, if what the patient needs. You can change the, so I have to think about it. You can change the formulation. You can also change the dose. So if the patient is not responding to the therapy, you can increase the dose. So you're allowed to prescribe within the same drug level. So patient is taking glyburide 5 milligrams and his blood sugar are very high, then you can increase it to 7.5 milligrams based on your clinical judgment. Document what you have done and send a copy to the physicians so that we would know what you have done. You don't need his permission to do it. You just need to inform them that he's been doing it. You're not allowed to do this adaptation for controlled substance. For narcotics, you're not allowed to do this. However, in my province, we're working to do de-prescribing of our narcotics altogether. You want to have the part of the presentation? Yes. Great. You will say I come from a pediatric hospital. I have to think if so. Oh, this is all his secret, by the way.
Yes, nice. My calendar.
Busy man. Well, let's talk about vaccination, because it's one of the school of practice. Most provinces allow pharmacists to vaccinate. Most interesting fact, when pharmacists started to vaccinate, the number of vaccinations by physicians went up as well. So as a population base, especially for influenza, there was an increased number of people that got the vaccine. The way we do it is very simple. In Ontario, everybody is entitled to the flu vaccine. It's free for everybody. I don't know if it's like this in Poland. And we can vaccinate any patient above the age of 5 years old. And trust me, below the age of 5, you don't want to touch his kid. They make too much noise. You don't want to touch them. Okay, I think it's good.
One moment. Yes.
Yeah, so
Should we go forward?
Yeah, 1 or 2 slides. Adapted. No,
Yes.
do you think it's going to work with you too?
We'll see.
She's one of our professors, and actually, if you type in...
In Ontario, pharmacists can adapt prescriptions in 4 ways. The first is by adapting the route of administration, for example, adapting an oral tablet to a suppository. The second is by adapting the dosage form, for example, adapting a cream to an ointment or a tablet to a liquid. The third is by adapting directions, for example, adapting from morning to evening, or from once a day to twice or 3 times a day. The fourth is by adapting dose. For example, you can correct an error. If the patient has been prescribed 500 milligrams, but they normally take 5 milligrams, you can adapt the dose back down to 5 milligrams. If a patient is on a drug that isn't working very well, you can adapt the dose up. Or if the patient has a side effect, you can adapt the dose down. Remember that adaptations do not include therapeutic substitutions. A pharmacist cannot adapt the proton pump inhibitor pantoprazole for the proton pump inhibitor omeprazole. A pharmacist also cannot adapt a monitored drug, including a narcotic, controlled, or targeted substance. Remember that if an adaptation is clinically significant, notify the prescriber. If the prescriber is a specialist, you should also notify the primary care provider, whether that's the family physician or nurse practitioner. If you change the effect of a drug by changing the dose, this would be a clinically significant adaptation. If you're doing a clinically significant adaptation, you should get consent from the patient or the agent and write down that you got consent on the prescription.
It was better on that screen, by the way. She was moving her lips on that one. So I think she explained well the adaptations. And then she will go back to my slide. I'll do the next slide. And I can change that.
Yes.
Yeah.
Now it works.
Okay, thank you. It's working. Okay, good. So, it's a bit blurry. So maybe it's my slides. So the thing, I can administer vaccine. I'm vaccination trained. I can also administer any drug for the purpose of teaching a patient. So a patient comes in and he's put on insulin. I can teach him how to use it, how to administer insulin. I can do it for him until he feels comfortable. So there's no limit number of time I can inject. For the purpose of injection of a drug is for the purpose of treating. That was negotiation with nurses, because nurses want to get the right to give the drugs. But basically, patient showed up with low molecular weight heparin or insulin, and we were teaching them, but we're not allowed to do it to them, and now we are allowed to do it. We talked about travel vaccine as well, and I think I'm going the wrong way. This is kind of a summary about the injection, and then probably will be available for you guys to look at this presentation. But depending on where you are, which province, you have different injection authority. The key thing is above children above the age of 5, because of the technique that is required to inject these small children. It's a bit blurred. So anyway, so some provinces will allow you to prescribe lab tests for the purpose of maintaining drug therapy. So in pharmacy, we can do blood sugar. You can do anything that pushes the skin to do a blood test. You can do cholesterol, blood sugar, INR, hemoglobin A1C. These are not paid by the province; they have to pay out of pocket. So not every patient are willing to go that way. You always have access to the lab tests as well. You can go. There's a central database in most provinces. You can look at the lab result of the patients. It gives you access. Most provinces, except one, have regulated pharmacy technicians, and they all licensed under the college, which would be the equivalent of the chamber. So a pharmacy technician to work has to be supervised by a pharmacist. and they must be licensed with the College of Pharmacists if they want to have the title of pharmacy technicians. We also have the title of pharmacy assistant. Pharmacy assistant is a little girl that you hire off the street, high school girl, to count pills for you, whatever. We count pills, but to do whatever you do in your pharmacy, like to do the cash and stuff like that. It's a pharmacy assistant. The pharmacy technician, they have a minimum of 12 months of education, full-time educations. They have to write a national exam before they get licensed, and they pay their due to the College of Pharmacists. And they are allowed to check a prescription, meaning the pharmacist is responsible to make sure they're clinically appropriate, so that it's safe to be given to the patient, and responsible for the counseling, but the preparation, the counting the pills and entering the stuff in the patient profile, dealing with the insurance, it's all done by technician, by licensed technician. I'm learning how to use that device. So people ask me, I've been asked by many people, how did we get there to provide this level of pharmacy services? I was trained, I've been a pharmacist 35 years, so I started my pharmacy school in 1979. Most of you were not born yet. Sadly, he said to me, yeah, I was not born yet, sadly. I'm old, I know. I spent 4 months in the hospital working with a physician at that point, during my training. Everybody would go through this. So they were training us to be ready to provide care tomorrow, not the next day we graduated. So I was already trained in 79, well, actually I did my rotation in 83, I believe before it was a 4-year program. We were already trained to provide the service of tomorrow, even though they were not accepted yet by the medical establishment. So our university have had this forward thinking. They're teaching for what will be required in 10 years or 5 years from now. It does frustrate the student when they start working because they want to do more. They're capable of doing more. Prescribing, most provinces do it now. We were trained, when I did my doctor of pharmacy, which was an advanced degree back there, we were trained to prescribe, how to do it exactly. And it was not, nobody had that in their legislation at that point. It was in 1990. And some of you may have been born. The point is that you need to have a university there. We always train I would train, my first year of pharmacy was with the medical school, in the medical school. So we had the same courses, except about 3/4 of the courses we had were with the medical students. So we were trained together. So when we come to work together, it's much easier, as opposed to have the physician on one side and the pharmacist on the other side. When I did my advanced degree in the doctor of pharmacy, we did one semester, the pathology course with them. And it was problem-based learning. We're 10 of us, and we're not allowed to be working together. We have to go and work with the physicians, so they learn how to work with pharmacists. So conceptually. And there are things about patient needs. It's about the fact that you need to meet the need of the patient, create expectation as well. Because if you only give boxes away, a technician can do it. You need to provide added value. You need to see that talking to a pharmacist presents something that they did not know. And you always have to find that sometimes I call it upselling. I'll give you an example. Metformin. If you're dispensing metformin, the patient's been on it for a long time, it's well established that you're more likely to have vitamin B12 deficiency. If you're taking omeprazole when you're metformin, you increase your risk because you need the acidity to absorb B12 in your stomach, and metformin decreases the absorption of vitamin B12. So when you dispense your metformin to your patient that comes regularly, and it's on omeprazole, you can tell them, did you know that you can have a B12 deficiency? I will sell you some vitamin B12. You can supplement by mouth. That's a good example of upselling, but it's also providing an added value of you providing the drugs, or looking at side effects. So this is how we get there. Any question for this presentation? I have how to become a pharmacist in Canada next. Any questions so far? Are you a bit dizzy? No, not too much dizziness. I can be there to answer more questions at the end. Let's go to the other part. Sorry, I'm always going the wrong way. So, I would say about 10 years ago, we had a shortage of pharmacists in Canada. And Immigration Canada came up with a process, which has been changed since then, where if you are trained as a pharmacist, you can immigrate to Canada much more easily. And you go in front of the file, basically. By the way, right now, we don't have a shortage anymore, which we're fine. Like, we double number of graduates, so we don't have a shortage, but it's still easier to get in if you have a pharmacy degree. There's a website, which is Pharmacist Gateway in Canada, which you need to get there to get registered. I'll explain this step. So This is how the website looks like, the step essential requirement, the cost, the language proficiency. Clearly, you must be truly bilingual, or sorry, you must be truly either Anglophone or Francophone. Even in Ontario, if you're truly only Francophone, you can get your license there because it's supposed to be able to provide bilingual services. But in Quebec, you have to be absolutely Francophone to be able to speak fluent French. You don't have to be Francophone, you have to be fluent in French. All the other province, that's a basic requirement. I'll give you some example of what it looks like for step for licensure. First of all, you have to pay a fee to get into the gateway. So we get registered with this is gateway. This gateway is managed by the regulatory bodies. So we have every province have their own college that regulate the pharmacy, or their own chamber if you want. The way and they basically are together, and so we want all the new registrants to go to that gateway. And then they will give there's an evaluation of your file. That costs money, of course. There's an evaluation examinations. Basically look at your basic science. Do you have the basic science as a pharmacist? Then, after that, if you pass that level, there is a qualification exam. Qualification exam is very simple. It's 2 half days of multiple choice question, testing knowledge. 1 half day of observation, where they bring in an actor that act as patient, and they are testing you on your communication skill and your capacity to identify drug-related problems. This is where the foreign trained pharmacists have problems, because in Canada, we are trained from the beginning, and we expect the pharmacists to talk to physicians and to talk to patients. And some of them are more shy, they don't have the structured approach. This is where usually they fail the most. And after you pass this, it's almost like you have to do your jurisprudence exam. Yeah, so basically, it doesn't apply to the regulatory authority. You may be required to do maybe an internship for 4 months, usually 4 to 6 months, and then you get your license, and you pay for it. This is kind of give you an idea of the cost, and you have to have access to this, so it can change. The gateway enrollment is $300 to start with. The evaluation of your documents, $650 Canadian. The evaluating exam, which is the basic science exam, is $615. The other exam, the qualifying exam, is $2,500. And I think I have the next slide that will explain a bit more. You have to do the bridging course. There's a bridging course that costs $13,000. It's a 1-year course, or 9-month course. You can get a waiver for this course if you pass the qualifying exam, so the exam right away. I can tell you the statistics. The people that do not take the course, that come from foreign country, their success rate to get that exam is 10%. The people that take the course, coming from foreign country, the success rate is 90%. So that makes a big, big difference. But it's $13,000 does not include, you have to go to Toronto. This is the very demanding course. Done paying. Then you have to read the jurisprudence exam. Every province have their own legislations. So you have to make sure that you study this. And that's the most boring exam I ever did in my life. Because I hated that exam. Only did it once, by the way. I did it once. And now I'm president of the college, I should know more, but still. Then there's registration fees, and then you have to pay your fee. This is Ontario fee right now. And I can tell you next week it's going up to $725, something like this, at the college meeting. And it's required by law in Ontario, and actually all provinces, that you have liability insurance, a minimum of $1 or $2 million, it's depending on which province you're in. So if you add the cost, it's not that cheap to become a pharmacist, even if you're trained. Now I'm done. Can I give my question mark? Any questions, any concern, anything about Canada you want to know? I can answer your questions. Don't be shy. The expression I would use right now, deer in the headlights. Do you know that expression?
One question. When the pharmacist can change dose,
Yeah.
for a patient, but consult with doctor, or can we change?
So you need to get the consent of the patient, and you don't consult the doctor. You tell the doctor you've done it. So you send them a fax. You've done it. It's within our scope of practice. Some physicians don't like it. Some physicians, this is within your authority to do so as a pharmacist in Ontario. Actually, most provinces have this.
Well, of course, you take responsibility.
Yeah. Yeah.
And you're changing that.
So right now in Ontario, we have the scope of practice for a few years. Nobody's been going in front of discipline for increased scope of practice. So nobody has been punished by the college. And we're not aware of any people that were sued because of using that scope of practice. People get sued in Ontario as pharmacists, like the civil suit, for not providing for counseling, for not checking for drug interaction.
The question is, what the doctors do actually?
You remember the video that we had earlier? The video said we're there to optimize the healthcare system. So there's all these things that common ailment. You don't need a doctor to diagnose this. So healthcare system like this, why should I pay a doctor $50 when you can go and see the pharmacist and maybe I would pay only $15 for the service? Because if you go and see the doctor, you have to pay the doctor, then you have to pay for the drug as well after it. And usually if you go and see a doctor, you end up using a more expensive drug most of the time as well. So that the healthcare system looked at this as more efficiency. Doctor should be taking care of complex patients. Doctor like taking care of AZ patients because they get more money, but the system doesn't promote this. There's plenty of work for doctor. We have an aging population. I don't know if it's the case in Poland, but our population is aging. The percentage of people above the age of 60 or 65, I'm getting to that group soon, but anyway, is increasing. So we need more and more physicians take care of these patients. There's plenty of work for them. That has not been a problem.
What is the number of doctors in Canada? Approximately, of course.
I don't know the number, but I can tell you that if I want to get an appointment with my physicians, within 1 week I have an appointment, no problem. And sometimes with my group, I can have it within the same day as well. So we don't have an access to physician in Ontario is a big problem. I think it's 1 for 2,000 people, 2,000 population. It's not. We don't have a shortage of physicians, and it's not a problem. It's access to the. They said on Ontario, if you go to Quebec, they have same number of physicians, but the physicians are structured differently, and they have a problem of accessing physicians in Ontario and in Quebec. But no, it's not a problem of shortage of physicians. I can find the numbers. So what are you going to be working on? What do you see Polish pharmacists being able to do next? Any comments?
They need to increase the self-confidence. That's for sure.
So pharmacists are, in Canada, the personality of a pharmacist usually come from a modest family, and they're more shy. If you look at nurses, nurses get everything, and I heard they get prescribing authority here. They're very vocal. Nurses are very vocal, like the women's like women's. Like I'm a woman. I've been like you've been under the doctor's authority, and for me. Type of approach. Pharmacists don't do this. The pharmacists don't complain as much to the government, and they basically just tolerate. We're more modest. We comply with everything. So it's very common, and I've been on my travel. The pharmacist is very quiet because they don't want to disturb. They want to upset the doctor. They don't want to upset the doctor. So and this is not the mentality. I was mentioning to someone today. My 19 pharmacists, my 120-bed hospital in reality, maximum patient we can really have. If the pharmacist doesn't talk to pharmacist, to physician, I don't want that pharmacist. I'm gonna fire them actually, because their job is to provide patient care, and their job is to work with the team to optimize patient care. That won't be a problem, to be honest with you, because the physician wants pharmacists. They're not lazy, but they give the problems to us. Sometimes easy problems, we can fix and give it to them. Like I had one pharmacist, a young pharmacist, who just graduated from university. After a year, she quit the job. Her reason for quitting the job, she said, the doctor do everything I tell them to do. I said, well, this is a good thing, but she was not secure enough in her knowledge. Then it was like, and then she left, and then she came back 3 years later, because she realized that other environment are not as nice as well. So you have to be confident, and you also have to make sure you provide good information. I started by doing pharmacokinetics. I was a hospital pharmacist. All I was doing all day long was doing pharmacokinetics, which is not that difficult, by the way. And the doctor did not understand pharmacokinetics, and he liked me because when I was giving him a dose, it was working after that. So you need to find a service that your patient wants and needs, that will also help the patients. Because at the end of the day, if the patient is upset, the doctor will be more upset. But the patient is doing better. Like we have pharmaceutical opinion in Quebec and in Ontario. We have pharmaceutical use review, but pharmaceutical opinion, you write a letter to physicians, and you get paid, I think, $15 to $20. I don't know how much. It's a lot of work. So what you do instead, you tell the patient, well, this drug is better, and you give them a bit of information, show them on the internet with the information, and go and talk to your physicians. So they go and talk to the physicians. You tell the pharmacist, but they have the evidence. So they will not negate what the pharmacist does. There's a way of doing it. I think being trained with physicians makes a big difference as well.
Have you visited any Polish pharmacy?
I then spent some time. I went to Radom.
Yeah, we went to Radom. Actually, we can tell about the project in Radom because it's going to be a Polish pride. Może ja wam powiem, słuchajcie, rozpoczynamy w ogóle mega projekt z opieki farmaceutycznej, pilotażowy. Będzie to projekt generalnie nazywa się to konsultacja farmaceutyczna. Oczywiście wykorzystamy pismo obrazkowe, bo to jest bardzo ważne, do konsultacji pacjentów onkologicznych. No i Radom generalnie przystąpił do naszego projektu jako pierwszy ośrodek w Polsce, pod nadzorem naszego kochanego gościa.
A to jest w tym nowym w jakimś szpitalu onkologicznym, czy?
Tak.
Tak? To jest dokładnie
tak,
w tym, tak?
Tak, tak,
Okay.
tak.
I just said that we just
Great.
started the project.
No,
Niesamowity entuzjazm w ogóle całej ekipy, która, że tak powiem, mamy bardzo sfokusowane badanie, bo o to w tym wszystkim chodzi. Mała grupa badana, weźmiemy pod obserwację 30 pacjentów na chemioterapii i chodzi generalnie o to, żeby poprawić jakość życia, tak? Przy odpowiedniej konsultacji, przygotowanie pomocy naukowych z wykorzystaniem etykietowania oczywiście obrazkami, bo to jest ważne, czyli narzędzia, które służy do konsultacji, bo to zostało tak naprawdę, słuchajcie, stworzone po to, żeby ułatwiać wam konsultacje. Po to też system, który wymyśliliśmy, on ułatwia wam konsultacje, żebyście nie grzebali gdzieś wiedzy, tylko ta wiedza jest wam podawana i też się uczycie dzięki temu, tak? Okay.
Sounds important. So one thing you can start doing tomorrow, which is within your scope, and it's fine, asking your patient, is it working for you? Or do you have any side effects from this drug? It's very easy, very simple. Your example that you were giving me earlier, you may want to tell them when you were telling me about the metformin. You can do it in a minute.
The first thing, which is, miałem pacjenta, który skarżyła się na dolegliwości układu pokarmowego i realizowała cyklicznie receptę na metforminę zwykłą. Zapytałem jej się, czy ktokolwiek doradził zamianę na metforminę o przedłużonym uwalnianiu. No i tak delikatnie powiedziałem, że poszła zasugerować to lekarzowi, tak? No i po zmianie jakby formulacji pacjentce ustąpiły do dolegliwości, a odwiedziła w międzyczasie 15 lekarzy, w tym z trzech z instytutem profesorskim i brała silne leki na nieswoiste zapalenie jelita grubego, tak? Więc no, takie chyba najbardziej spektakularne do tej pory przykład, jaki w sumie bardzo prosta usługa, tak? I bardzo proste wpadnięcie po prostu na to, tak? Bo to jakby nie chodziło o kwestię wiedzy, tylko zauważenia tego sposobu pomocy pacjentowi.
Okay, powiem wam jeszcze jedną historię w ogóle, jeśli chodzi o poprawę jakości życia pacjenta. Czy ktoś z was wie, co robi generalnie sok grafitowy w przypadku sildenafilu? On generalnie powoduje, że następuje wzrost stężenia sildenafilu we krwi. Czyli możemy oszczędzać pacjentowi pieniądze. Mniejszą dawkę, żeby więcej pił soku grafitowego. I to jest właśnie opieka farmaceutyczna.
Yes. But just asking, and then because the patient will be, you're providing a service to them. You're just not giving them medication. You're asking them, is it working for you? If it's not working, you can tell them, well, these other drugs can be the same family. You can discuss it with your physician. It's very simple, because sometimes it's not working, they don't know what to do. Or they have side effects. Is it working for you? Do you have any side effects? And a lot of side effects can be managed by changing something, or even something with food or without food, with grapefruit juice, without grapefruit juice. Type of example. We need to provide an added value to the patient. You need to see it. They must be happy. You have spent a second or 2 minutes. They didn't take 2 minutes. It takes 1 minute with you as a pharmacist. From a competitive advantage, if they have a choice of going to see the pharmacist that provides that care for them versus the one that just gives drugs, he will go and see you. Give you an example. When he came to Canada, I was working in the community pharmacy on the Quebec side. I was licensed in Quebec. Patient will line up to wait for me. They will wait for me to talk to me because they knew I would care for them and ask them specific questions. And they will answer their questions or look into their problems more than the other pharmacists. So they will come to you. But I will start with a very basic and doing a systematic way. And it's easy to learn this. Something like, do you have any questions for me? Meaning like, sorry, so what question do you have for me? as opposed to, do you have any question for me? Do you have any question for me means you should not have any question. If you have a question, you're stupid. Which question do you have for me? It's like, you should have question for me as a pharmacist. Ask me. You understand? There's a small, it's very English type of different, but it's a very big difference.
Can I add something on to?
Add something, another
Powiem wam coś ciekawego. Chodzi o działanie pożądane na przykład. Dużo się mówi o tym, pacjenci czytajcie ulotki. Okazuje się, że bardzo duża część pacjentów po przeczytaniu ulotki, to jest 50%, przestaje brać leki. W niektórych krajach nawet sięga 86%. I teraz, po co jest konsultowanie generalnie pacjenta? Na przykład, słuchajcie, podam przykład mojej mamy, ona jest lekarzem dentystą. Ostatnio mi przepisali atenolol. I wiecie jakie działanie pożądane jest atenolol? No tak kręci się w głowie, tak? I trzeba powiedzieć pacjentowi, żeby wolno wstawał. I co robi pacjentka, której nikt nie powiedział o tym, że kręci się w głowie? Po 2 dniach się źle czuje, odstawia lek, tak? Powie o tym lekarzowi? Absolutnie nie. Czyli nie bierze leków, nie leczy się, tak? Jakie ryzyko generalnie, powiedzmy, problemu późniejszego? Gigantyczne, tak? Więc o to chodzi. I teraz to, co my robimy, przygotowaliśmy narzędzie do konsultacji pacjenta, do przekazywania wiedzy. Więc to nie jest tak, że obrazki są banalne. Obrazki są bardzo potrzebne, ponieważ w sposób obrazowy. Sam obrazek nalepiony na opakowanie nie daje efektu. Ale tłumaczenie, po co on się tam znalazł i po co to jest ten zawód głowy narysowany, to jest właśnie konsultacja farmaceutyczna, a my stworzyliśmy do tego narzędzie.
I agree. So, the other thing that can be done as well, which is fun to do, is I'll give you an example of drug interaction checking. Looking at all the patients, the patients taking with drug interaction. My hospital, we're fully electronic. So the doctor prescribes electronically, we get this electronically, we have barcoding for everything. So they have the possibility as doctor to see the drug interaction as they prescribe. All the doctors said, we don't want to see this. We don't understand drug interactions. Then it's only the pharmacy, it's the pharmacist actually that says drug interaction. And based on our opinion, we will intervene with the physician. So, and this is right now, like, so we did this a year ago, fully electronic, like it's a long, big project. Years ago, they did the same thing. They provided doctor with drug interaction software, and they increased the number of phone calls to the pharmacy, because they get this interaction, don't know what to do. They just don't know what to do. And we should be trained, in Canada, we are trained to manage drug interaction. This is what we do. So another way to get more involved with your patients. Any more questions? I think you should add the closing remarks. You're in charge of them.
Okej, moi drodzy. No nie macie pytań żadnych? Mogą być po polsku. Przetłumaczymy. Jeżeli macie wątpliwości, czy... Prawda, czy myślę, że warto. Jeżeli nie macie pytań, to wam bardzo dziękuję za przybycie, ale na pewno nie macie.
Jakie macie pytania?
Jakie macie pytania?
After passing all these exams for foreign pharmacists, how much do they earn? It's good to know it before we assess.
No, that's good. It's good to know. The minimum salary will be $30 an hour. It's between $30 and $60 an hour. If you want to work in Toronto, you'll earn $30 an hour, because many pharmacists want to Toronto. If you go up north, you can earn $60 an hour pretty easily, which is about $100,000 a year, about that. Good living usually. But if you want to stay in the big centers, my pharmacist in my hospital, they get a pay raise, but they're unionized, get whatever they want. Most of my pharmacists will make $100,000 and $105,000 a year in a hospital. In community, in Ottawa, it's about $45 to $50 an hour. And a house costs about $300,000, like a very basic house in Ottawa. That's my project.
To może chcecie zapytać, od czego powinniśmy zacząć w Polsce? I czy warto robić przeglądy? Pewnie wszystkich interesuje. Maybe we should talk about medicine use review? Whether it's a sufficient service? Or...
I don't think so. I think they have now.
Moja propozycja jest taka, oczywiście, jeżeli będzie możliwość uzyskania prezentacji, byłoby świetnie. Myślę, że każdy z Was sobie będzie miał jeszcze możliwość zerknięcia na tą prezentację. Ja Was gorąco zachęcam do tego, żebyście faktycznie przybyli na ten dzień aptekarza. Zachęcam Was z jednego ważnego powodu, że tam będą ludzie, którzy będą mówili o tym, jak opieka farmaceutyczna i jak wykonywanie zawodu wygląda na świecie i w Europie. A znowu to mi jest potrzebne do tego, abyście, kiedy zdecydujecie się przyjść tutaj do nas, żebyśmy mogli ze sobą porozmawiać o tym, jak byśmy widzieli, jak byśmy chcieli tak naprawdę to podmienić, bo dużo się mówi o tym, że w Ministerstwie Zdrowia jest zespół do spraw pilotażu, że będzie pilotaż, że prawda, będziemy robić przeglądy, a tak naprawdę moje głębokie poczucie jest takie, że to właśnie my czy Wy osoby, które na co dzień widzicie z pacjentami, musicie nabrać takiego z jednej strony poczucia, że to ma sens, a to ma sens, wszędzie ma sens. Wszędzie na świecie, gdzie odpalono opiekę farmaceutyczną, to ma sens i farmaceuci robią to, o czym mówi Regis, w mniejszym lub większym stopniu. Z tym, że tak jak Wam powiedziałem na samym początku, do tego, żeby to się stało, będziemy potrzebować entuzjazmu, pozytywnego nastawienia i takiego wzięcia spraw w swoje ręce. Takich właśnie, gdzie tutaj dzisiaj to nie padło, ale chociażby takie przygotowania informacji dla farmaceutów, czy chociaż przetestowania w którymś momencie informacji, które chcemy dla Was przygotować, żebyście przeczytali, zobaczyli, czy dla Was tam jest wszystko zrozumiałe, czy wszystko jest tak, jakbyście Wy ze swojej strony praktycznej to widzieli, bo oczywiście opieka farmaceutyczna, mimo tego, że podobnie wygląda w Wielkiej Brytanii, w Kanadzie, w Portugalii, to tak naprawdę tam są drobne różnice wynikające z różnic w społeczeństwie, w wykształceniu, w kwestiach językowych. Nawet nie wiem, czy wiecie, jakie jest podstawowe pytanie, które powinniśmy zadawać w aptece, kiedy ktoś przychodzi z inhalatorem, to jest mój akurat konik. Kiedy ktoś przychodzi do Was i mówi, i chcecie się upewnić, czy chcecie sprawdzić, czy on wie, jak stosować lek, jakie mi pytanie zadajecie?
Proszę pokazać, jak Pan to używa.
Takie pytanie powinno paść. Nie, czy Pan wie, jak stosować lek, tylko proszę mi pokazać. To są takie drobne elementy, o których będziemy chcieli z Wami rozmawiać, z jednej strony, z drugiej strony to też chodzi o to, żeby pewne idee, które powstają dotyczące opieki farmaceutycznej, od razu zdarzyć z praktykami. Nie zrobić tego w 2-3 osoby, gdzie coś poklepiemy po plecach i stwierdzimy super, zrobiliśmy super projekt, a potem się okaże, że kiedy Wy dostaniecie w ręce, to powiecie w ogóle bez sensu. Tak, więc ja do tego Was gorąco zachęcam, abyście w dalszych spotkaniach uczestniczyli. Znaczy, generalnie też zachęcam do tego, żebyście śledzili Piotra informacje, strony internetowe, na których publikują nam dużo informacji, które oczywiście możecie znaleźć w internecie, jak będziecie szukać.
Tak,
znajdziecie, ale prawda też jest taka, że może po prostu jest łatwiej. Jeżeli ktoś to znajdzie, ktoś wskaże Wam źródła tych informacji w internecie, w języku angielskim, są tony. Tak naprawdę my troszeczkę cierpimy na tym, że nikt nas jeszcze nie nauczył korzystać ze źródeł. Naprawdę farmaceuci w Polsce, takie jest moje głębokie poczucie, być może Wy jesteście tym wyjątkiem, ale to zasady my nie bazujemy na źródłach, na wiedzy pozyskiwanej ze źródeł naukowych. Tak jak powiedział Regis, farmacja jest nauką. Mam takie poczucie, że chciałbym, żeby kolejne lata w tej Izbie były oparte o tym, że przygotowujemy dla Was wkład merytoryczny. Nie rozmawiamy tylko o kwestii tego, czyja jest apteka, nie rozmawiamy tylko o tym, czy jest reklama, czy jej nie ma, tylko rozmawiamy właśnie o tym, jakie są procedury, w jaki sposób pracować w aptece, o co pytać pacjenta, a żeby to stworzyć, tak naprawdę będziemy potrzebować Was, farmaceutów, bo co powiem teraz z dużą, że tak powiem, z dużym rozżaleniem, takim poczuciem, że to nie do końca jest tak, jak być powinno, ale niestety ze strony uczelni póki co nie mamy wsparcia. Tak naprawdę to uczelnie, jak dzisiaj powiedział Regis, to uczelnie powinny być w to wszystko zaangażowane i powinny tworzyć tak naprawdę ten cały wkład merytoryczny. My w Polsce takiego komfortu nie mamy póki co. Więc być może będziemy w stanie to jakoś przeskoczyć, działając wspólnie i szukając drogi. Być może znajdą się wówczas akademicy, którzy będą gotowi wejść w ten pomysł taki, bym powiedział, projektowy, myślenie projektowe, nie w myślenie dyskusje niekończące się, tylko wejście w projekt, który ma początek i koniec i potem ma zostać wdrożony w jak szerszej ilości miejsc. Ja mogę mówić długo, więc nie będę Was tutaj zagadywał. Jeszcze raz gorąco Wam dziękuję za przybycie. Troszkę nowych twarzy widzę, każda osoba, która po raz pierwszy tu przychodzi, mam nadzieję, że jeszcze będziecie tutaj zaglądać, mnie bardzo cieszę. Chciałem, żebyście w tym wszystkim uczestniczyli, bo to, jeżeli byście mnie zapytali, dlaczego w Polsce pewne rzeczy nie idą tak szybko, jakbyśmy sobie chcieli, to ja Wam mogę odpowiedzieć już jako osoba, która gdzieś tam po tych 3 latach, gdzie jestem zaangażowany w samorząd i w te wszystkie prace na różnych poziomach, mogę Wam powiedzieć jedną rzecz, dlatego, że za mało osób się zajmuje. Za mało osób jest zainteresowane tym, żeby te rzeczy popychać do przodu. Oczywiście to nie jest uwaga do Was negatywna. To jest raczej też moje wewnętrzne poczucie, że trzeba każdemu farmaceucie, który nawet jeszcze nie wie, że chce, dać możliwość podziałania i jakby zaangażowania się w coś, co go interesuje. Bo ja rozumiem, że nie każdego musi interesować czytanie aktów prawnych, nie każdego musi interesować chodzenie do Sejmu, czy tam handryczenie się w temacie protestu takiego czy innego, ale w temacie takim, gdzie możecie sami się dowiedzieć dużo i popracować troszeczkę na czymś, co wejdzie być może na pewno w Polsce w którymś momencie. Myślę, że każdy z Was będzie zainteresowany, także też będę bardzo szczęśliwy, jeżeli skorzystacie z tej oferty i będziecie gotowi tutaj przyjść. Być może na początku to nie będzie miało jakiegoś takiego bardzo charakteru bardzo bym powiedział, ustrukturyzowanego, ale myślę, że też od tego trzeba zacząć, że najpierw przyjdą osoby, które są zainteresowane, wymienimy się wiedzą, ja się z Wami chętnie podzielę wiedzą, którą ja mam międzynarodową, też mam tych źródeł sporo, jestem w stanie Wam je wszystkie pokazać, chętnie się z Wami tym podzielę. Jeżeli się okaże, że czegoś nam brakuje, jestem w stanie tą wiedzę zdobyć i się też z Wami podzielić, a też będę Was gorąco wtedy zachęcał do tego, żebyście dzielili się swoimi wnioskami i tym, w jaki sposób możemy tę wiedzę wykorzystać. Także z mojej strony już tyle. Thank you, Regis, for coming to Poland. It's a great occasion to meet you. I think that each information which you gave us is opening our minds, really. So I think that maybe not tomorrow, but in a few next months we will be able to look on those data, to remind your information, and I think that we will push forward. And if possible, please answer for our emails. We will write to you, we will ask you about your opinion and recommendation, as I asked you during our discussions, and I hope that you will be able to help us, because I think that we are on the beginning of our road to the pharmacy services in Poland, to gain the level which is in Canada, UK, or other countries. So thank you very much for coming, and I think that I can tell you for all pharmacists which are here that we adore what we are doing in Canada. Really. Dziękuję bardzo. Jeżeli się oczywiście Wam bardzo śpieszy, to nikogo nie zatrzymuję. Jeżeli ktoś chciałby o czymś porozmawiać, chcielibyście zobaczyć chociażby izbę, to Was chętnie oprowadzę, to już zależy od Was. Jeżeli komuś się chce pić, tam jest woda. Wiesz co, będę je anonsował na październik. To będzie miał prześwitamy farmaceutyczną, pojechaliśmy na miesiąc. Zostawimy stoły.